some serious attrition here. I didn't see any bodies out there. How's the pace? Is it doable? It's fast. Yeah, there's a lot. Yeah, we've whittled it down. It's sort of trying to find this balance of how much to give you this absorbable in an amount of time that you have. My sense is that our third and fourth years perform very well on their clinical rotations based on what we do in the first 2 years. And I certainly feel like, given the amount of time, we give you the highlights of cardiology. Hopefully, what you learn in the first 2 years is that you have to steadily learn to be a good physician. And a lot of the material that we present to you is new information every 5 or 10 years. And so hopefully we also teach you about critical thinking. That's really important. And the lecture this morning, the first one on chest pain, is all about critical thinking. You know, when you're sitting in an emergency room and somebody comes in with chest pain, you know, it might be a sore rib or it might be a heart attack. You know, go home and take Advil, or I'm sending the ambulance to the hospital. And so getting this right is really important. And if you get it wrong, it can have disastrous outcomes. So it's sort of fun to think about clinical things, isn't it? Isn't that nice? I mean, you busted your chops, you got decubitus ulcers from learning basic science, and now this is all clinical today. I'm going to just talk to you about clinical stuff. So I think it'll be fun, hopefully. It'll be fun for me. So here are my disclosures. I have not received any new grants since the day before yesterday, but I'm always dredging, looking. Okay, so we're going to talk about angina pectoris, pericarditis, aortic dissection, differential diagnosis. I want you to think about differential diagnosis of chest pain. When you're on the ward with me next year, patient with chest pain, I'm going to say, so what do you think? And you're going to say, well, you know, this patient's symptoms to me could be one of 4 things, 1, 2, 3, and 4. I think it's 1 because of, but we're not completely sure, so the diagnostic testing I've initiated is X, Y, or Z. And the therapy we started last night is this. So the differential diagnosis is to say, well, based on history, physical, and limited information otherwise from tests, this is what I think it might be. And sometimes it's obvious, and sometimes it's not at all obvious. So your differential is bigger. So differential diagnosis, we've got to think about life-threatening causes of chest pain. I want you to be sure you leave here with a sense for the life-threatening causes, the ones you can't afford to miss. Aortic dissection, and we want to talk a little about Reverend Bayes. Okay? We'll talk about Reverend Bayes at the end. All right, so we're going to talk about cardiac causes, GI, musculoskeletal, aortic, pulmonary, and then psychologic. Okay, that's going to be the tour this morning. So we learned the other day about angina pectoris, or angina, right? Typically retrosternal tightness. Saw a guy yesterday, had a stent a month ago, and he said to me, you know, a week or so after my stent, when I walk, I get this burning constriction. When I stop, it goes away. I asked him if it was acid or heat. He said it's hot. I get short of breath with it, too. And I thought the stent would fix that. It's angina pectoris. He's having angina pectoris. It can radiate to the neck, jaw, shoulders, arms, wrists. Left greater than right, but both. Some patients just have right arm pain with their angina pectoris. It's brought on, we talked about, by stress. Some patients, it's only mental stress. I have patients who say, when I get in an argument with my significant other, I get chest pressure. What should I do? I say, stop arguing. I took care of a person who got unstable angina every year at tax season. And it was because her husband actually was a gambler, and she would sort of find out at the end of the year that we're out of money, and that wasn't good. So the cure to her angina was actually turning in her husband and getting another one. Angina typically lasts only a minute or two. It's not going to be 30 minutes, and it's not 2 seconds. I saw a patient this week who said, I'm really having, I'm having that thing you described, that fullness. I said, tell me about it. He said, well, it comes like this. Oh, really? Does it happen with exercise? No, after exercise, when I lay down, I feel like that is a little tightness. It's probably just a premature ventricular beat. Angina isn't like that. It stays for at least a period of 30 seconds or more typically. Okay, and it's usually relieved within a minute by effective nitroglycerin therapy. And we talked about the fact that when you're actually having angina, there is frequently a change on the EKG, and that's what we're looking for when we do stress testing. When we do stress testing, we're trying to bring out angina if a patient has a symptom that might be that. And we're also trying to see if it correlates with an EKG change, which most typically is ST depression. Okay? I saw a patient yesterday, 45-year-old, who walked 18 minutes on the treadmill. He got a little tightness late in his test, and then his ST segments dropped in recovery. Positive test. We reproduced his angina. He had ST depression, actually not during the exercise, but when we stopped him, his EKG changes happened, and they lasted for about 10 minutes after that. We actually gave him a nitroglycerin to get rid of the EKG changes because he was having ischemia, but the pain was gone, but he was still showing it on his EKG. Okay? So this is angina pectoris, very common cause of chest pain. Some patients will you say, well, tell me again about your chest pain, Mrs. Jones. And she says, I told you it's not pain. It's a strange sensation. And every patient feels it differently. Bart Giamatti was the president of Yale University before he was the commissioner of baseball. Interesting transition, Yale to baseball. He was having indigestion after meals, and he loved big Italian meals. So he was pretty sure his postprandial indigestion was GI, and he was taking all kinds of Rolaids and stuff. And then he had a big episode of indigestion, and he died. It was a heart attack. It was preceded by angina, but it was postprandial indigestion that he didn't respond to. He didn't take it to the step of getting a physician involved. So you can see all kinds of things with angina. Pericarditis. Saw a 30-year-old. Yes, sir.
I have a question about the transient ST elevation on the previous slide.
Yeah, it's usually ST depression. Rarely we see transient ST elevation.
So if we see, I was under the impression that if we see ST elevation, that's more of a sign of an MI than it is.
And it usually is. But if you do a stress test and the patient develops transient ST elevation that goes away, then it's probably an occluded artery. They're getting transient transmural ischemia, and when they stop doing their exercise, they come back toward normal. That's a different scenario than if somebody walks into the ER and says, Doc, I'm having chest pressure, and they have ST elevation. That's an MI till proven otherwise. Okay, most of the time when you see ST elevation, it's going to be in association with a myocardial infarction. But occasionally when we do stress testing, we'll see transient ST elevation. It's much less common than ST depression. But it's a bad marker. It's a high-risk lesion typically. Okay? So pericarditis, this pain is typically sharp, and it's worse with a deep breath. It's in the chest. It may be in the shoulder blades in the back. The patient usually likes to sit up. When they lay down, then the heart is resting on the pericardium, and during cardiac motion, there's more irritation. So these patients want to sit up. Sometimes they're just doing this, they're walking around like that. Occasionally they say, I feel better when I get down on all fours. I feel best right down here. Do you want to take my history now? So this is very sharp pain. And a lot of times the patients, it's so severe when they breathe that they actually shallow breathe. You see, they sort of purse their lips. They don't want to take a deep breath because it irritates the pericardium more. All right? If you listen to them, we talked the other day, you hear this rub. So with the cardiac cycle, much different than a murmur, which is a whoosh, whoosh, whoosh. This is a sound like rubbing paper together. And it's often, you're hearing ventricular systole and diastole. It's even possible to hear atrial systole, so sometimes it has three components. Okay? Friction rub. You hear it more sitting up or forward than laying down. So when you hear the rub. I saw a 30-year-old yesterday who has recurrent pericarditis, probably viral. He had a bad virus in the fall. He got terrible pericardial pain, got admitted to the hospital. We cooled him down with anti-inflammatory drugs, and it's come back twice now. He's on immune suppression, trying to get his immune system to stop doing this. Some insult created a reaction where his immune system is identifying trouble in the pericardium and keeps revving him up with probably lymphocytes and white cells. Now, the EKG of this is very important. Remember the PR segment? The PR segment from the P wave to the QRS. That's actually often depressed in pericarditis. It's very strange. Don't know why that happens. So if you see, let's say you're taking your test and there's a patient who comes in with pleural sharp chest pain, and that says the EKG shows PR depression. That would be pericarditis until proven otherwise. The other thing about pericarditis is it can cause ST elevation, but the ST elevation is not convex, it's concave. So it's not tombstones, it's the prudential rock, right? And it's in many leads. When we see ST elevation heart attacks, they're usually going to be in 2, 3, 4 leads. With pericarditis, there's ST elevation everywhere. You think, whoa, I'm seeing ST elevation in all 12 leads, or maybe 10 leads. That would be very rare for a heart attack. I mean, it'd be massive. But it's typical in pericarditis. So pleuritic pain, PR depression, diffuse ST elevation, but it's not convex. It's not tombstones. It's like the rock. Okay? Do you know what I mean by the rock? Ever been to Diamond Head? The Diamond Head in Hawaii, that's a beautiful rock. It sort of slopes up like that. So it's kind of upsloping ST depression, not rounded convex ST depression. Prudential, doesn't Prudential have like it's Diamond Head, I think. I don't know. Gastroesophageal reflux, GERD. Some of you probably had this. I have this after a particularly heavy meal with lots of red wine. This is retrosternal burning too, but it's typically acid. The patient often says, I taste it. I taste that bitter. Have any of you ever had GERD? No. One person. I had it. So GERD is common. It's often brought on by foods, particularly when people lay down. So it's going to come on at night. Typical scenario, came home, had a huge meal, went to sleep, and boy, I woke up feeling this terrible burning pain. Oh, really? What was it like? Well, it was burning. Hot or acid? Oh, it was acid, and I could taste it too. I had this bitter taste, this brackish water taste in my mouth. Gastroesophageal reflux disease. And it's relieved by antacids. And if it's chronic, we put patients on acid blockers, proton pump inhibitors, omeprazole, things like that. You're going to learn all about those in GI. It's not relieved by nitro, so this can be helpful. The patient comes in, I develop chest discomfort, burning pain at night. You're in the ER, and you may give this person a nitroglycerin as a diagnostic maneuver. And it doesn't go with nitro. You give them some Maalox, and it's gone. You say, okay, I think we're fine here. EKG looks good. Your symptom responded to antacids, not nitro. I think we're fine. All right? Don't have to rush you to the cath lab, right? Okay. Now, there's another type of GI pain, peptic ulcer disease. This is typically epigastric, so it's going to be high in the abdomen. It's aching or burning. Again, it's more likely acid, not heat. It's often after meals. It's not exertional. GERD is not typically exertional. It is, occasionally you see it, but when you see exertional pain, you're thinking, angina, right? This is not exertional. It's often a gnawing pain at night. These patients say, I'm not comfortable. I have this ache. I get up and I drink milk, and it's better. So that might be peptic ulcer disease. It's relieved by antacids. It's not relieved by nitroglycerin. Esophageal spasm is a little bit more difficult to deal with. It's substernal discomfort, spasms of pain. When this patient is having esophageal spasm, it may be so much that they actually have difficulty passing the food. So, they say, I'm eating and I get this discomfort, and I actually cough up the bite I just ate. What's with that? So they're having enough spasm, they're actually getting anatomic obstruction to passing the food particle into their stomach. Okay? This is typically precipitated by meals or drink. It's not exertional, but nitro relieves smooth muscle cell spasms, and the esophagus is loaded with smooth muscle cells, so it actually is relieved. Esophageal spasm is typically relieved by nitrates. So just because the symptom was relieved by nitrates doesn't mean, it's for sure angina. There are GI causes of chest pain that can be relieved by nitrates, most typically esophageal spasm. Many patients who have GERD, gastroesophageal reflux disease, also may have a bit of spasm, okay? So they may have both. They may describe, reflux up into their throat, and occasionally, if it's bad, they may also say, when this is going on, I just don't feel I can eat right. I have to cut up my food into smaller pieces, okay? All right, that's esophageal spasm. Gallbladder disease, yes, ma'am. Usually not. Usually what we do is it's a good question. The question is, do you prescribe nitro for esophageal reflux? Normally what happens, often esophageal reflux is esophageal spasm is actually precipitated by reflux. So if we treat their reflux tendency with proton pump inhibitors or acid blockade, their tendency to esophageal spasm is also relieved. So I don't think I have a patient in my practice who gets nitrates for esophageal spasm. Now they may self-treat because they've learned it works, but it's not recommended. Okay? Biliary colic. So gallbladder disease is very common, often in middle-aged women, but men, more often in overweight individuals. Typically, the discomfort is in the right upper quadrant. It's typically a deep pain. It's a very deep, aching pain. It's often constant for minutes to hours. A good way to do this, to bring this on, would be to eat a stacker at BJ Stacker at Burger King. Do you know the story about Burger King? So a few years ago, the new CEO of Burger King said, you know what? We should serve people healthier meals. So he started a whole series of heart-healthy salads, and guess what happened? Their market share bombed, and said CEO got fired. So the new CEO came and said, you know what? I'm going to learn from my prior CEO. We don't want to do salads. In fact, let's take what we do now to the extreme. Let's offer the full Monty. So you can get 5 patties, 5 layers of cheese on a BJ Stacker, and I think it's about 1,200 calories. That would be a perfect thing to give somebody with gallbladder disease to see if they have gallstones, because a heavily fatty meal is often going to be the precipitant of gallstone pain. So typically it's postprandial. They may say, you know what, I can't eat ice cream anymore. I used to like cheese, doc, but for some reason I can't have it. Why? Well, I get a funny gnawing pain here in my right side, or I feel like there's this sort of painful belt that goes right around here. And it's just after I eat ice cream. Okay? Repetitive pain, deep, gnawing, postprandial. You're going to think about gallbladder disease. And it's not relieved by antacids. This is not a problem with acid secretion or acid reflux. It's a gallstone. Okay? And it is affected more by fatty foods. Costrochondritis, remarkably common cause of chest pain, thankfully a very benign problem. Of course, you know this. We have, let's see, we have a sternum, and we have ribs that come into the sternum, and where they join, those are joints. Ah, okay. And you know what? Joints can get inflamed. You most typically know this when you have a little arthritic pain in your knee. But these joints can also get inflamed. Often after an illness where you coughed a lot, or it may be a medical student who moves to Ann Arbor and is lifting heavy boxes and suddenly gets some inflammation where their rib cage and their sternum join. And they can have fairly impressive pain over that region, and it can be bilateral. The costrochondral junctions are sensitive. It's usually worse on the left side, and it's relieved by anti-inflammatories. If it's very bad, sometimes we'll inject it with a steroid to try to cool it down. You know, it's interesting. You can have patients who have a bit of anxiety, and maybe they've had a family member who had a heart attack or perhaps died of a heart attack. And when they get this, you know, they're listening to the radio, the 3 signs to watch for, you know, and they're feeling this terrible pain. Because it hurts, they don't want to take a deep breath, and they say, oh, I'm short of breath too. And then they're also anxious, and they start to sweat, and suddenly they're in a full-blown panic attack from costochondritis. They come to your clinic, and you palpate their chest, and they practically jump off the table. In fact, they say, don't do that again. You're pissing me off. That really hurts. It's very tender. So point tenderness over the inflammation. And you know, you do it once and you're going to know what it is. All right? So costochondritis is very common, all ages, your age, my age, and it's often recurrent. Patients who have it once often will have it again. And it's treated with anti-inflammatories. Cervical radiculitis, sometimes, if we get cervical spine disease, it can affect a nerve root, which will actually lead to discomfort in the chest. Okay? It's often constant pain, but it's, yes, sir. Yes. Well, you know what? I'm not sure. It could be because most people are right-handed, and so if they do activity with their left side, maybe they're more likely to stress their rib cage. I don't know the answer to that. I don't know the answer to that. I'm sorry. I'm truly sorry. I don't know the answer. But it is common on the left. Radiculitis is a constant pain caused by nerve root irritation, often a cervical spine issue, cervical arthritis. There is nerve root compression and irritation, and in a dermatome, there's this deep nerve pain. Have any of you had nerve pain? It's just so different from other types of pain. It's deep, and it's almost paralyzing when you have it. So this kind of pain is usually constant. It may be shooting. It's in a dermatomal distribution typically, and often if you manipulate their neck, you can either relieve it or make it worse. Okay, so you're sort of doing this, and you do this, and stop. That's probably cervical arthritis or nerve root irritation causing cervical radiculitis. Okay, so you're getting the picture here. When you see a person in the ER with chest pain, you got to have your wits about you because we're all over the place here. Chest wall, GI tract, gallbladder, cervical spine, coronaries. Anything, any structure from here to here is fair game with chest pain. And you got to be thinking about all of them when you take your history. Now, the one you can't afford to miss is this one, the John Ritter syndrome, aortic dissection. This pain is typically massive when it starts. When a person has their aorta tear, the pain is usually absolutely dramatic when it starts. An example, I see a patient who's had a heart attack, and they say, you know, this morning I got up, I didn't feel very good. Around 8 o'clock I had my breakfast. Sometime between 8 and 8:15 I started feeling some tightness here. The patient who dissects their aorta, here's their story. I got up, I reached down into the medicine cabinet, and it happened. And I fell to the ground. I was in such pain. They have a photographic memory of when it started. It's like being shot from the inside out. That story is really important for you to get. When you see a patient who's had chest pain, you have to go back to the beginning and say, I know you're feeling fine now, but please tell me how it started. What were you doing? What was it like? And sometimes you get these people an hour or two later, they had funny chest pain someplace and somebody did it and they sent it to you. We didn't know what was going on, so we gave it to you. And their pain may have gone away. A lot of times in aortic dissection, the pain goes away. Patients say, it was awful. I fell down. It was so bad. I sweat. My wife said I looked awful. I was like white. And now I think I'm better. Why don't you send me home? Now, if you hear that story, boom, you got to think about aortic dissection. Usually it's in the chest or the back, but it can be the belly. So it can be sudden severe onset of abdominal pain. You may see a pulse deficit. So if blood flow to the right arm or the left arm or the carotid arteries or a leg is affected, there may be a pulse deficit. So we take the blood pressure in both arms. If there's a big drop, like a 30-point drop, I'm 140 over 80 on the right and 110 over 60 on the left, look out. The left subclavian is involved, and I'm not perfusing my left arm normally. So you want to check the pulses, carotids, wrists, femorals, feet. And if there's a big difference in the pulse in one of those regions, you think, I got a problem here. I got sudden onset of chest pain and a pulse deficit. That's aortic dissection till proved otherwise. Okay? Sometimes the dissection is right above the aortic valve, and that dissecting hematoma can push down on the sinuses and disrupt how the aortic leaflets coapt. So it might push down a sinus, and suddenly they're not meeting, and there's aortic regurgitation. So you listen to them sitting up, and you hear this little diastolic murmur, backflow. They'll often have a systolic murmur, just this little backflow that's aortic valve insufficiency because the dissection has disrupted the normal functioning of the aortic valve. So the physical finding is of either aortic insufficiency and or a pulse deficit. In a patient who's had sudden onset severe chest or back pain, bang, you say, I'm thinking aortic dissection until proved otherwise. It's life-threatening. I can't miss this. How do you diagnose it? CAT scan, most typically, or echocardiography. Okay? Aortic aneurysms can occasionally cause chest pain if they've been unrecognized for years. As they grow, they may start pushing on things. I had a woman who I took care of. She started having steady, gnawing back pain. And I saw her, I did a chest x-ray. Her aortic shadow looked big on chest x-ray. So I got a CT scan, and her aorta was like 8.5 centimeters. Way too big. Yours is about 3.4. Hers was 8, and it was pushing on her thoracic spine, causing pain in the back. So aortic aneurysms that are symptomatic, they're pushing on something. There aren't really afferent nerve fibers in the aortic wall typically that cause aneurysms to be symptomatic, but they become symptomatic when they push on a structure. They might push up on your recurrent laryngeal nerve, and you start having a hoarse voice, not from allergies like me, but because nerve function to your voice box is affected. Or they can push back and partially occlude the esophagus. So the patient says, geez, it's funny, when I eat, it's like stuck. I can't swallow my food properly, doc. What could it be? You're thinking esophageal, and you're thinking right, but it may not be an esophageal problem. It might be an external problem, either a tumor or an aneurysm that's blocking esophageal motility, okay? So they can have a cough, they can have dysphagia, or other symptoms from local compression. Pleurisy is very common in the fall and spring, typically viral. Inflammation of the pleura. It's sharp pain. It's worse with a deep breath. It's very much like pericarditis. And they often go together. You may see a patient who's got both some pleurisy and some pericarditis. The symptoms are really the same. You may hear, again, they're worse lying down. They want to sit. It's interesting. Heart attack patients usually say, I want to lie down. Patients with pericarditis and pleurisy want to sit up. They say, I'm much more comfortable sitting, thank you. Say, well, I want you to lie down. Well, it hurts when I lie down. Can't you do your exam when I'm sitting up? Well, some of it, but some of it I need you to lie down briefly. Maybe we'll put you down a little bit. I have to feel your belly. Pleurisy, they want to sit up. And when you listen over their affected lung, you'll often hear a rub as the lung descends and ascends. Okay? It's sort of a rubbery sound that when that lung fills, there's just this scratching sensation. Now these people, because it's usually induced by a respiratory infection, they often have fever, cough, and they may have sputum production too. Okay? So viral pleurisy, very common cause of chest pain. It happens in young, healthy people like you. And it's nasty. It hurts like heck. We treat the infection, and we can treat the pain with anti-inflammatories. Aspirin, Advil, usually helps. Pulmonary embolus. This is the second lethal condition I don't want you to ever miss. Pulmonary embolism, sudden, severe. Possibly they'll have pain. They typically are very short of breath. So their chief beef is usually shortness of breath. But their second beef is, I also feel pain. Okay? This is normally a massive clot, which is causing a pulmonary infarction, causing discomfort because the pleura is infarcting and it's not happy. Okay? Sudden onset, severe shortness of breath with pain, pleuritic again, and you're thinking about what would predispose this young man to a pulmonary embolus? Broken ankle, riding on an aircraft for 20 hours, got immobilized in a car accident. Oh, has a family history of clotting. His parents both had pulmonary emboli when they were 24. These kinds of things. When you look for PE, you're thinking for a reason. And often it's surgical or orthopedic. Okay? So these patients come in, they have a fast heart rate, and when you put the oxygen saturation device on them, they're desaturated. They got an O2 sat of 88. Yours is 99.9. The respiratory rate's 40. Yours is 18. Their heart rate's 110. Yours is 64. And if they have a low blood pressure, that's a very bad prognostic sign. It means the right ventricle is really hurt. It's trying to get blood through a major clot in perhaps multiple proximal pulmonary arteries. Okay? Pulmonary embolus, cannot afford to miss this one. I saw one, it's really unfortunate. It was a football player. I mentioned this the other day. He had knee surgery, went home, was in rehab, came back, was feeling kind of shortness of breath, and the doc saw he's anxious, sent him home. Came back 12 hours later dead, had another PE, and passed. When you see somebody with shortness of breath and chest pain after orthopedic injury or repair, you're all over this. You can't afford to miss this one. Because if you do, they often will have another one or two, and it might be the last. Okay? Don't miss pulmonary embolus. Panic disorder. You're probably feeling that right now. So much material, so little time. I'm starting to feel chest pain. I can't get my breath. It's like pressure. It could be an MI. No, it's just too much material, okay? This is constant, and often these people have a sense of constriction. It's like tightness. Have any of you had panic? I've had panic. It scared me to death. was unbelievable. I was having migraines. I thought I had a brain tumor. And then I started having panic disorder. And it was awful. I mean, I was breathing fast and had tightness. And, you know, it took my internist to kind of pull me off the ceiling. This is scary. Constriction, they're short of breath. If they hyperventilate, they may actually get a little bit of circumoral numbness, or their fingers might get tingly from blowing off so much CO2. That's very helpful. They say, you know, I get this funny feeling in my face. Then you're thinking this. You know, and they describe recent unusual stress. I have actually never met a person who said no to this. Have you? I mean, have you ever met a person who says, oh, no, I've never been stressed, particularly lately? So we're all stressed, but this stress is usually unusual. You know, loss of a loved one, major split up, you know, going to medical school, things like that. And these are recurrent. They're often in healthy young professionals like you and me, being nice to myself, young professionals. Recurrent, and usually easily handled just with reassurance. Occasionally we have to use agents that are anxiolytics. That means they lyse anxiousness, right? And that can be helpful. All right, so that's panic. Now testing, when you think then about, okay, I got a patient with chest pain. I have a differential diagnosis. Now I have to decide, okay, what's most likely? And then I'm going to do testing to see if I'm right or if I'm not right, if it's number 2, 3, or 4. So the testing is ordered based on your index of suspicion. You're not going to, you know, I got 8 causes of chest pain, there's 25 tests, I think I'll just do them all, and everybody will be happy. No, the national government won't like that. We've been doing a lot of that lately, and it's time to stop. We need to take a good history, do a really good physical exam, look at the EKG and X-ray, and then say, okay, here's probably what it is, let's look. So the EKG is good to find myocardial ischemia and pericarditis, right? So angina or MI, we're going to see ST depression, ST elevation. Pericarditis, we're going to see that diffuse ST elevation, PR depression. The chest X-ray may be very helpful. We might see the aneurysm, or if an aorta is dissected, it might be enlarged, so that aortic shadow is bulging. You say, oh, geez, the aorta is big here. For GI causes, for reflux, we may be doing endoscopy or an upper GI study where we have them swallow barium and look for spasm or reflux. Okay? For the gallstone, we're going to do an ultrasound, or we can do a CT or MRI of the right upper quadrant. Aortic disease, typically we're going to do chest CT or maybe echocardiography, also MRI. In this day, we don't use MRI as much for aortic disease and heart disease because we have a tight certificate of need law in Michigan that regulates how many magnets the state can have. So we have about 75% fewer magnets than other big health systems like, say, Mayo Clinic because of state regulation. And since MR is so important for brain and orthopedic stuff, it's hard for us to get a cardiac study in there. Okay, so we'll end up using CT because it's available. They run the MRI scanners 24/7. You know, if you sign up for an elective MRI of your elbow, you might be assigned a time of 3 a.m. That's painful, at least to me. That's painful. Esophageal motility studies are for esophageal spasm. You do a study, look down, I think it's okay. There's no reflux, but the patient continues to have problems. We can actually put a probe down and measure motility of the esophagus to try to find evidence of spasm. Okay? That's called esophageal motility studies. Pulmonary embolus, most of the time we're diagnosing that with a CT scan, which has an angiographic component. So it's a set protocol to look at the blood flow in the pulmonary arteries. Okay? There's also a study called a ventilation perfusion scan, which one can do. That is studying ventilation in all zones and then using a nuclear tracer to look at perfusion in the zones, looking for areas of mismatch. Nowadays, CT angio is probably the most commonly used. For angina, we can use stress testing that you and I talked about, or we could do an angiogram not with an invasive catheter, but with a CAT scan. So we have this fancy 64 or 128 slice per second scanner that goes, and you look at the coronaries that way. Okay, so you might be doing a CAT scan in the emergency room looking for a patient who you think could have angina. Both tests are quite helpful. They measure different things. Stress test tries to bring out ischemia. A CT angiogram is looking for anatomic evidence of blockage, atherosclerotic blockage. So they're looking at different parts of the same disease. For pericardial disease, we might do a 2D echo, and we can do echo also for aortic dissection in the proximal aorta. We can see it. With echo probes, we can see the proximal aorta. The arch is tough. The arch is sort of a silent zone for an echo probe. And the back is very difficult to see with echo, so we do CAT scanning for thoracic aortic disease, most typically, right? We can look at the aorta by putting a transesophageal probe down and looking with ultrasound. So it's called TEE. So say the first patient comes in with sudden onset chest pain, we do a 2D echo and it looks suspicious. Then we'll go right away, we'll numb the throat, give the patient a little sedation, pass a probe, and use an echo machine right next to the aorta through the esophagus to see if there's a tear. Okay, that's called transesophageal echo. So that gives you a brief snapshot of kind of the range of 8 or 10 things that are most common causes of chest pain you're going to see in your ER, in your families. You're going to become you're going to be the medicine advocate for this whole fraternity and sorority of people that surround your life. You know, I get stuff virtually every day from somebody, oh, I just heard, would you mind looking at this? You're going to do that. And when it gets to chest pain, these are the 8 or 10 things you're going to be thinking about. And when you order your tests, they will be directed based on your suspicion, where the top thing in your differential diagnosis, this sounds like pericarditis. I might do an echo just to make sure there's not a massive amount of fluid. It's mainly a clinical diagnosis. I'm going to treat it for that and see how they do. Maybe I'll cycle a couple of enzymes to make sure there's not myocardial damage. But this at least introduces these themes of chest pain, differential, testing, treatment. Now, Bayes' theorem is this concept. So Reverend Bayes, cool dude. Did any of you study Reverend Bayes at all? He was a reverend, late 1700s. And he wrote math by night. It's like he's the dark night of math. He wrote math formulas, and he thought his ideas were so whacked out that he never published them. He stored them in a shoebox. And after the Reverend met his maker, one of his friends discovered all this stuff and says, you know, this is kind of neat. I'm going to have somebody look at it and see if it's important. And it was important. It was the basis of Bayes' theorem. Bayes' theorem is so important. And it's all about probabilities, right? The likelihood of an event in a population depends on 2 probabilities. The first is the overall likelihood that this population of folks would have that kind of thing happen, then modified by a test I did on one of them to determine her or his probability. So if you said, give me a great example of Bayes' theorem, it would be doing nuclear stress testing in first-year medical students. I don't think any of you have important coronary disease. My prior probability of that is really low. And if I know the false positive rate of nuclear stress testing is 10%, look out. If I tested you all, and 15 of you had a positive stress test using nuclear imaging, what would be the likelihood that those positives have CAD? Low, because the prior probability in your class has got to be minuscule. So Reverend Bayes promoted this idea that the prior probability has a lot to do with what you end up with after you do a test. And if you ignore it, you're going to be very disappointed in all kinds of tests. Prior probability, test result, post-test probability. Okay? So am I making any sense? Good. At least one of you said so. So here's an example. Yes, sir. It depends on my prior probability, right? So if I'm looking at a young person who's describing chest tightness, I'm probably going to try to find out. I'm watching them, seeing if they look anxious and if they're breathing fast, and I might go right to that. You look at it and say, "Geez, this person looks kind of anxious. I wonder if they got panic disorder." So there's no right answer to that. And as you learn in medicine, you'll end up asking questions in an order that is trying to get you to the answer as fast as you can, but not too fast. And when you're a third-year medical student, you'll ask all the questions that you've ever learned. And after a while, you'll start to realize that, there's certain patients where I nailed it in 3 minutes, and I'm done here. I need to move on. But in the beginning, you'll ask more questions. And, the good news for you is patients like to be asked questions, most of them. Okay? So Bayes' theorem. Here's an example. This is having to deal with the probability of major coronary artery blockage in patients with chest pain. And it illustrates the fact that the frequency of obstructive coronary atherosclerosis differs by gender and age. Okay? So here's 3 groups. No symptoms. These patients have atypical angina, and these people have typical angina. And then this looks at age groups. And these numbers reflect the percent that have at least a 50% blockage on their coronary angiogram. All right, so let's look at a young patient who has typical angina. If it's a male, there's a 70% chance when you do the cath they're going to have obstructive disease. If it's a female, it's only a quarter. Only a quarter. If they have atypical angina and you're young, your woman, is very unlikely you're going to find anything. Not until you're 65 or more does it even pass a 50% threshold. But in a male at 45 to 50, atypical angina really has, look at that, it's a 3-fold difference. If you have no symptoms, then, the evidence of coronary disease in a population, the prior probability is growing, isn't it? Eventually, women catch up to men, don't they? Eventually, they have as much. Because coronary disease kills more women than anything else in the world, by far. In this state, by far. In this town, by far. But they catch up after the age of 65 because they don't start till 10 years later. Their disease comes 10 years later on average. So big differences here. What you see is huge differences in threshold depending on age, gender. This is all about prior probability. So you got your prior probability, age, gender, and then here's the test. What kind of symptom do you have? And then you see the post-test probability of disease. It's a great illustration of Bayes' theorem. Now, it's important that you recognize that when this study was being done, the investigators didn't realize that there are lots of women who had typical coronary disease symptoms, but their angiograms look good. This is quite interesting. Postmenopausal women have a much higher chance of getting a diffuse coronary artery problem. They get angina. They have a positive stress test, and you cath them, and it looks nearly normal or normal. The golfing partner of my father-in-law sent me her records this week. She got seen in upstate New York, had typical angina on the golf course, had a positive stress test. They did a cath, said it looks pretty good, sent her home. She's still having her angina. I looked at her cath report, and it said there's a few 20% blockages, but in the distal LAD, the flow is sluggish. She has diffuse coronary disease. It's not a big segment that's blocked. It's diffuse. She's having angina. It's causing symptoms. I called her and I said, we're going to do aspirin, statin, nitrates, one other anti-anginal. I want you on a low-fat diet. You can't smoke. We got to lose weight. I want you to walk. Your prognosis is good. Your heart muscle's normal. But she might have been one of these. You know, she's, let's see, she's 55. So, you know, she's got about a 1 chance out of 2 that her calf looks good. But she does have coronary disease. It's just a different kind. It's not these upstream. I'd call it lumpy bumpy versus smooth. Men get lumpy bumpy coronary disease more often. Women get smooth coronary disease more often. I'm generalizing badly, grotesquely. All right, but that's Bayes' theorem. So let's take a 10-minute break, okay? And then come back and we'll go through a single person's journey through a series of health catastrophes, okay?